Okay. So thank you for meeting with us, Dr. Dafoe. I just wanted to start off with a quick question of what is your name and title and what procedures do you work on?
Okay, I'm Dr. Donald Dafoe. I'm in charge of the kidney transplant program at UCI. I've been doing kidney transplants for 40 years. And I also do pancreas transplants. I also do liver recoveries. UCI doesn't yet have a liver transplant program, so I recover livers from heart-beating brain dead donors for other programs all over the region.
Great, thank you. And so what's important to know about, you mentioned about 3 disease conditions there that you work with.
Right. The main disease that we deal with is what's called end-stage renal disease. And the causes are primarily type 2 diabetes, which is increasing in the population, hypertension, and then there's a grab bag of a number of other entities. Some are genetic, like polycystic kidney disease. Some are, in the, I guess you'd say, environmental or unclear etiology category, such as glomerulonephritis, Wegener's disease, Bright's disease, a whole slew of other diseases. But diabetes and hypertension would be the main ones. I mentioned type 2 diabetes. We also have patients with type 1 or so-called juvenile onset diabetes.
Great. And what's been historically done to treat these conditions?
Okay. Dialysis for renal failure started way back in around World War II. And it was a crude, interesting sausage casing arrangement where blood was run through sausage casing in a drum, and the toxins were leached out. And then nowadays we have efficient dialysis machines but they still require 3 to 4 hours a day on dialysis 3 times a week for people with end-stage renal disease. Dialysis will keep someone going, but it's not fun. It's, as I said, it's very restrictive. They're on the machine for that period of time. They have restrictions in what they can eat or drink. And between dialyses, they often don't feel real great. It's kind of like wringing out a dish rag, and then it fills back up with water, and then you have to wring it out again. There is something called peritoneal dialysis, where a tube is placed in the abdomen, and then fluid is sloshed around using a octopus-like looking machine at night. And fluids run in and out of the abdomen, and the blood is cleansed that way. But really the best form is to replace the kidney. And that's what I do, kidney transplants. And that involves, obviously an operation where we implant a kidney and place the patient on immunosuppression to deal with the foreignness of that graft. And to fight against rejection.
So you mentioned dialysis and the kidney transplants is the procedure you perform. So you mentioned that replacing it, making sure that they accept the new kidney. Is there anything else you'd like students to know in terms of that procedure that will help solve basically the ultimate solution to that problem, right?
Sure. The procedure was first done in a less refined way in Boston in 1954 between identical twins, where one twin had renal failure and the other didn't. That's the way the technical side, the surgical side of transplantation started, because between identical twins, there's no immune barrier. And then it developed to what it is today, which is use of human kidneys from strangers, altruistic donors, relatives. People donate one kidney, they'll live a normal life with the remaining kidney, and then we sew that in. The way we do it is a little different than some people might conceive of, in that unlike the heart or liver, we take out the old and put in the new, we leave the old kidneys in place up in the back area, the retroperitoneum, and they tend to just shrivel up. And we put the new kidney down in the pelvis through an incision, about a foot long incision, to one side or the other of the lower abdomen. And kidney comes in with an artery vein in the ureter. So the artery brings, the oxygenated red blood and nutrients to the kidney. The vein drains the kidney, and then the ureter, the filtrate, is run down the ureter into the bladder. That takes place, 3 to 4 hour operation. Nowadays, people are only in the hospital 5 to 7 days. When I started, everyone was in the hospital 6 weeks, and almost everyone had a rejection episode. So nowadays, the drugs are so good that the incidence of a rejection episode, which we can usually reverse, is only 15%. So 85% of people sail through without having a rejection episode. Those kidneys don't last forever. On the average, about 15 years. So sometimes younger patients who get a kidney transplant are looking for another one down the road, or will need one down the road. So we still have problems with acute rejection. And even though the drugs are very good, it's a cocktail of 3 drugs that we usually use chronically. And people must take their drugs religiously, or they will have a rejection of that graft. So that's the immune response of the recipient to the foreignness of the graft. So the 2 big problems in transplant, the surgical technique is pretty solid now, and it hasn't changed much in the last decade. So I don't see a lot of development there. The 2 big problems are the need for chronic immunosuppression, because those drugs have side effects and they're not perfect. So we lose grafts over time due to chronic rejection. The other big problem we have is the donor organ shortage. So even though the public awareness of donation, should a loved one die in a situation where they can donate, that's increased. But overall, there haven't been big strides in the number of kidneys in the US that are transplanted every year, which I believe is about 20,000. So we need a way of dealing with the organ shortage. And many people die waiting for kidneys on dialysis. So it's the biggest problem we have. But I can talk about what's coming down the pike, which is pretty exciting.
Yeah, that would be a great transition. Out of curiosity, what 3 drugs in the cocktail are typically prescribed?
Okay, the mainstay is called tacrolimus, and we have a second one called mycophenolate mofetil, and then prednisone, which is a steroid and anti-inflammatory. And then we use something called thymoglobulin for induction, meaning that when we first do the kidney transplant and the body's being exposed to, again, these foreign proteins, we use, interesting, an anti-human rabbit antiserum to condition the immune system to accept those grafts early on. So what's coming down the pike? Well, we need, ideally, there's something called tolerance, where you manipulate the immune system to the point where it's up and vigilant for infections and cancers and what have you, but blind to the foreignness of the graft. And people have talked about tolerance for a long time. We're not making a lot of headway there, frankly. So we still rely on the drugs, and they're not perfect. So there's certainly room for more drugs, We have some targeted antibodies to treat rejection. There is movement there in biotech, but we still have as our foundation for immunosuppression the same 3 drugs that we've had now for 15, 20 years. So we need a breakthrough there. The most exciting thing to me is xenotransplantation. So that's, across species lines. And primates don't work well there because they don't breed well in captivity. It's hard for people to accept, putting down a chimp or something because they're so human. And anyway, long short of it is the pig looks like the candidate. People won't have quite as warm feelings, although I had a pet pig once and they're pretty great. But anyway, so pig organs are about the same size as human. And just recently, out of the University of Maryland, you may have heard of this, a pig heart was placed into a human. Last I heard, that was still going after about 6 weeks. That barrier across species lines is huge and usually causes hyperacute rejection where the graft crumps. After you sew it in, it turns blue and it dies. So this was no regular pig. This was a pig that's been genetically modified in a number of ways using CRISPR technology and knockout technology. So this is coming. And for we transplant surgeons who, are up all night getting these organs and then putting them in, it'll be wonderful. Not of course for the patients. Don't mean to be so self-centered here, but surgery will be done electively when everything's optimized. But more importantly, there could be an endless supply of replacement parts, not just for kidneys, but for basically every organ, probably except the brain. So that's real exciting. That's what I would bet on. There's also stem cell technology, cellular transplants, building organs, using dot matrix technology. I mean, there are a lot of exciting developments. In that realm, it's mainly structural things that can be built, but it's early yet. So they have tracheas, the windpipe have been transplanted, made by, cellular stacking of cells and building structures. But to get a functional organ like a kidney is much more complex, or a liver. The other exciting development is that when these organs come out, they begin to deteriorate because they're no longer getting oxygenated blood going through them. So currently, we flush them out using a preservation solution. We put them in ice, and then the clock starts ticking. So for hearts, it's only 6 hours. For kidney, we can stretch it out as long as 36, but we usually get most kidneys in within 20 hours. For the liver, it's about 12 hours. So now what's happened is instead of just putting them in ice, there are companies that have developed basically little extracorporeal membrane oxygenators, which would be a system that is hooked to the organ and sends it, using a little pump, oxygenated warm blood. So they would call this, for example, heart in a box. And if you see this, it looks like something out of a 1950s horror movie. There's this heart beating wildly inside a glass box, and it's alive because it's getting oxygenated blood. The same is true for the other organs. So with the liver, I recently talked to the CEO of the company called Transplants. He believes, and has data to show that some livers can make it out 5 days using the warm oxygenated perfusion. It's cumbersome, certainly more expensive, but that will help us a lot because we can ship organs around and not have them deteriorate. So that's another development that's coming up that's exciting.
Great, thank you so much. And just my final question, would there be any advice for our future medical students and biomedical engineers out there that you want to give?
Well, mine's what I tell the surgical residents, I'll say, but the general thing is find a discipline within medicine, and I'm surgically oriented, where it is looking good, but not there yet. So, you know what I mean? If something's at their peak and everyone's doing it, you know, then that's going to fade away eventually. It'll be replaced. When you see something new, for example, 30 years ago, it was laparoscopic surgery. You know, if you get on board that train, then, you know, you've got these refinements with the robot and all. Now, if you've, you know, come along over those 30 years, developing learning minimally invasive surgical techniques, you'll be top of your game. And not to be too self-referential, but myself and other transplant surgeons, you know, rode that wave from 30, 40 years ago. And it's been so amazing and so gratifying. So I would say, you know, look at a field that's developing, looks really promising, that over your lifetime of a career is going to improve greatly and benefit patients and be a very satisfying career, an exciting career, because along the way, there most certainly will be improvements in biotech and, you know, psychosocial as well. But again, as a surgeon, I look more at the biological and the surgical aspects of things.
Great. Well, thank you so much.
Okay, my pleasure.